This is our first meeting of conference committee on S.126. And we think that the best way to sort of start with this is Jen, Legislative Council, is going to put up the marked up version that was done for the Senate from the changes that the House made to the Senate version.
Great. Good morning, Jen Carby from the Office of Legislative Counsel. I will put this up on the screen. And so I have titled this as passed by Senate, showing markup from House. And so all of the changes should be in bold and highlighted in yellow. So S.126 is an act relating to healthcare payment and delivery system reform. We start off with section 1, the purpose and goals. So the Senate version had that the purpose of the act is to promote the transformation of Vermont's healthcare system. The House revised that to say the purpose is to achieve transformation of and structural changes to Vermont's healthcare system. And then there are specific goals. And so do you want me to just go through a section and then stop and let you discuss, or do you want to talk about it?
I mean, let's go. We don't have to do every single word, but there are things that will be important.
How about if we if anyone hits on words or phrases or something that they have a question about or don't care for?
So my question is regarding continuing on to global hospital budgets. The Senate proposal was to have global hospital budgets. And I know that's a recurring event through the bill.
Okay. Is there anything in section 1 on the purpose and goals that that is just deplorable?
There's nothing there, or that there's nothing other than that one that really stands out.
Okay.
Wait, other than which one? The number 3 has continuing rather than it does not have continuing on with.
Oh, right. Okay.
Then I do have a question on page 2, which is you talk about preserving the dignity, and I don't know how you preserve dignity legislatively or action wise. So that's just a question about.
This is all part of the goals. In enacting this legislation, the General Assembly intends to advance the following goals. And this is establishing
a healthcare system that will attract and retain high quality professionals.
Let's develop.
So just as
Representative Goldman's language,
Okay.
I take your point well. How exactly do you
I don't
preserve
know.
someone's dignity?
I don't know. It's just a question about what that means.
How about value the dignity?
Just a question. So let's hold that thought there. Okay.
Right, then we get into hospital budgets and payment reform. Section 2 is amending the duties of the Green Mountain Care Board. And in general, the differences here, I think this one is really just a clarification on page 3 that we're talking about hospital fiscal year 27, because that language, I believe, was in the Senate version later on for reference-based pricing. But the main difference here is really whether the board's duties are establishing standards for global hospital budgets.
That's a very large question for us.
Yeah. So I think, the House position, by the time we had gotten through sort of the whole meat of the bill, was we were really focused on the implementation of the reference-based pricing in sort of resetting, realigning, particularly hospitals. And because, this gets into the head model, that should we be, if not everyone is participating, not all payers are participating, should we focus on sort of resetting using reference-based pricing rather than immediately going to global hospital budgets when we know that it's possible that not all payers will be participating, Medicare, as well as the self-insured market. And so what we did was instead we moved, and I think that there were also some concerns around the budget piece, the fiscal impact of this bill, and putting our resources in the immediacy right now, and then having the Green Mountain Care Board, once reference-based pricing has been implemented fully, having them report back to us to say, okay, should we now move forward with global hospital budgets? How do we do that when we don't have an all-payer system? And we would only be relying on Medicaid, which Medicaid is already, I think Medicaid has 5 hospitals currently that they've moved to for global Medicaid payments. And so we were really just talking about this very small section of the market, the individual, the small group. And is that really feasible? So that's why we sort of took it out.
Okay,
The aspiration of it is, I think, what we are trying to do with reference-based pricing. And using that as because when you do that, when you do reference-based pricing, you're getting to all payers instead of global hospital budgets. So what is your thinking?
okay. I hear what you're saying.
Oh,
I can add another thing too.
Okay,
As we go through reference-based pricing, I think it would be easier for us to understand what a global budget would look like because we've got the experience of the reference-based pricing.
okay. And I do think that we've asked the board in previous years to come up with global budget parameters and to look at that. That's an ongoing work at the board. And I'm not sure how you hold a cap on hospital expenditures without having a global budget for the hospital. So that is where we are with that one. And so we will have to debate this one very much. Moving forward with only reference-based pricing will perhaps leave us without the change we'd like to see in cost containment.
and I will say the other reason why we put it in the reporting section was every single witness that we asked had a different definition of what they thought of as a global hospital budget. The Green Mountain Care Board actually said global hospital budgets are what we do now. It's the exact same thing they do now with capping revenue.
Exactly.
And nobody could even agree what a global hospital budget was.
Okay, well, we'll have to come back to this
Okay.
then, because this one is important to the Senate position.
Okay.
May I ask a question?
Sure.
Did you take testimony other than that last comment that you made to sort of corroborate all the other things that you said about the global budgets? I'm just curious.
Did we take testimony? We took testimony from AHS regarding the global budgets that they do. And that was a perfect example of the differing definitions around what AHS thinks a global hospital budget is and what the Green Mountain Care Board thought a global hospital budget was.
Okay.
AHS, I mean, there's the opinion that it is, here's a lump sum of money, here's how much money you're gonna get.
Mm-hmm.
That's a global hospital budget.
Mm-hmm.
And then there's also the Green Mountain Care Board's definition, which is, here's how much you're allowed to collect.
Okay.
And, you know, just having agreement upon what it actually was.
Mhm.
Is it the Maryland version? Which, when Maryland,
Maryland, Rhode Island,
Maryland.
Pennsylvania, there are different states and the board has been looking at those, so. And I don't know that, I personally don't think we need to have a report back on this. There's a lot of work going on, and so we'll keep looking at it.
Okay.
Okay.
Okay. What is this? This is showing markup from the House, and so
on the Senate,
maybe on the Senate's website.
I don't know if I had it posted. Megan posted it.
I can
We'll get it
take it
posted.
down and send it to, you just send it to.
We don't have an assistant. Our
Yes.
committee's shut
I
down.
know.
We can't, we're limited in being helpful, but do the best we can.
knowing the value that Kristen
Yeah.
adds to our committee, I can't imagine how difficult it is for you without Kiki.
I sent it to Kristen so she can post. All right, so then we get to section 3, which is the reference-based pricing. This is amending 18 USA 9376. The House did strike some language in an existing law that talks about access to primary healthcare services being specifically for underserved individuals, populations and areas. That's
Is
not-
there a reason why that was struck?
Yes, because it would concentrate on just primary care for underserved individuals, populations and areas. And I think that we realize that it should be access to primary care health services for everyone.
This isn't specific to reference-based pricing. This is the Green Mountain Care Board.
Right, this is their current rate setting.
Authority,
Yeah.
but there was some concern raised in the committee
Okay.
about why the focus specifically on
Yeah.
those individuals.
When we know we have access
Yeah.
issues for everyone.
All right, when we get to the reference-based pricing subsection here, subsection E, I think the big difference here is a different approach in the House that has the board establishing reference-based prices that represent the maximum amounts that hospitals shall accept as payment in full for items provided and services delivered in Vermont. The Senate version had been looking at what health insurers would pay. This is what hospitals would accept. And then it also suggests the board may implement reference-based pricing for for non-hospital services by setting minimum amounts that would be paid.
So I believe that what this does is it expands those self-insured that might be included and others that might be.
This
included.
allows us to
Any
have
provider.
to have consistent amounts or maximum amounts that hospitals would accept and pay as payment in full. It is payer agnostic.
As the board regulates hospitals, we decided to focus it on what hospitals could pay rather than what insurers could,
Hospitals could accept.
what hospitals could accept.
So then within on line 15, also, you struck neutral, site neutral pricing structure. That anywhere else?
I think there was my recollection is there was testimony that reference-based pricing did not necessarily move to site neutral pricing, especially if the idea was to give the board the flexibility to set the prices that were appropriate for different providers in different parts of the state, and with different patient mix.
We wanted to, and first of all, I'm a big proponent of site neutral pricing, but with reference-based pricing, we wanted the board the ability to right size the reference of what the reference is, or not what the reference is, but what the amount is based upon, and not be constrained with, okay, you in Newport get this amount, which has to be the exact same as you in Rutland get the same amount. And because each hospital has different payment mechanisms, different, Medicare, we wanted to give them the flexibility to be able to set the rates
if you extend this outside of hospitals, then that might be that, and I think that was perhaps the why this is here. So this is professionals, healthcare professionals rather than just
Well, it's
No.
the definition of healthcare professionals for the chapter includes
Right.
hospital, includes
Yeah.
facilities.
Yes, and I think we got to that in another section.
okay, we'll
Within-
look at it.
When we're asking about outside of hospitals.
Okay.
For them
Got
to
it.
look at reference-based pricing outside of hospitals.
Okay.
Um, all right, so some of this I think is more just clean up differences.
Yeah, there were some places where you pick language up and put it somewhere else.
Right, so they're right. So some of the language on line 16 through 18, I think there was thought that it was already captured elsewhere in this
Mhm.
subsection. And so it was taken out here. The change on line 21, I think, was really expanding the board's consultation with various stakeholders, is not specific to ways to approach reference-based pricing in an effort to achieve all payer alignment, but just more generally in developing reference-based pricing, including ways to achieve all payer alignment. So it's broadening the scope of that consultation a bit.
Yeah.
Balance billing, this prohibition on balance billing is just moved. The House version moves this up, but so you'll see it struck later, but it's the
Yeah.
same
I saw
language. And then again, a little bit of somewhat clean up the Medicare reimbursement piece. They've taken out specifically the reimbursement rate. There was some interest in looking at also Medicare reimbursement methodologies in some instances, but that may not be appropriate in all instances. So there was a suggestion to simply take out the word rate and just have it be based on a percentage of the Medicare reimbursement. And then recognizing that the board may be using and
Yep.
specifically authorizing the board to use other payment or pricing systems where appropriate. So then it's not just initial prices, but if the
Don't
board
get
uses
stuck.
Medicare, they can use a different index.
Yeah, don't get stuck.
Yeah, they don't.
Okay.
If Medicare doesn't have.
Yeah, we got it. That one's fine.
And then just a little specificity here on hospital and moving the reference. I think this may have been somewhere else, but there was interest in also looking at the hospital's role in Vermont's healthcare system when setting rates for a particular
Yes.
hospital.
This all makes sense.
So again, making some changes that reflect the move away from looking specifically at health insurers' plans
Mhm.
and instead, but keeping the timing of hospital fiscal year 2027. And then adding specific language that the board would review the reference-based prices for each hospital annually as part of its hospital budget review. And then we have
Yeah.
striking the balance billing language that was just moved
Right,
higher.
it's all there. Got it. Okay.
A little bit of a language change here. There was concern about specifically requiring there to be a commensurate decrease in health insurance premiums, recognizing that there may be other reasons that, or other ways that decreased amounts show up. Depending on payer mix and otherwise, so just looking to ensure that decreases in amounts paid to hospitals also result in decreases in health insurance premiums, but it may not be
One-to-one.
one-to-one.
Right, got it.
All right, then we have the board identifying factors that would necessitate terminating, and the House has added or modifying the use of reference-based pricing in one or more hospitals. And saying an example is a measurable reduction, not just any reduction in access or quality, but a measurable reduction.
Oh, okay.
And then we have, this should be highlighted, but the change from, it had been the Agency of Human Services in consultation with the Green Mountain Care Board. Now we have Green Mountain Care Board in consultation with the Agency of Human Services. And adding in the first reference here to the Comprehensive Primary Health Care Steering Committee that you will see later. Can implement reference-based pricing for services delivered outside a hospital, such as primary care services, and may increase or decrease the percentage of Medicare or another benchmark as appropriate. And then it specifically says the board may consider establishing reference-based prices for services delivered outside hospital by setting minimum amounts to be paid in order to prioritize access to high-quality healthcare services in settings that are appropriate to patients' needs.
So,
So this is,
I'm not, sorry to interrupt, but shall be paid. And so going back to the concept of receiving.
right, so it gets harder to do that when you're trying to incentivize higher reimbursement rates for certain types of care. If you were trying to incentivize higher reimbursement rate for primary care services and you set the maximum amount that a provider could accept, then the payers could pay less. So in this case, it suggests the way to do it may need to be by setting minimum payer amounts, even though that may reduce the
Okay,
numbers of which
that was
payers are paying.
you answered my question, but yeah, it seems.
But it's a may in case they come up with other ways.
Yeah, we had to flip it back to the insurer side on this
Right.
one.
Okay. Then,
And then we specify in subdivision 6 here that the board's authority to establish reference-based prices does not include Medicare or Medicaid.
again,
I think everybody knows, but
Which everybody knows that the EHS was very firm in making sure we have that in there.
and we have section 3A. This is a new section in the bill, but not new language. This is the definition of hospital network and adding this into the beginning of the subchapter on hospital budget review rather than having it in the new standalone section on hospital network review. So it's a different location, but it's not a different.
it's the same,
concept.
yeah.
But this means it applies when we use the phrase hospital network in 9456, the hospital budget review statute. Section 4 is hospital duties with respect to hospital budget review. And I've just noted here that the existing language is being removed from the bill, but not repealed. So when it's being shown as struck out here, that doesn't mean that the House is proposing to strike the existing language from statute.
But try.
So this removes some additional provisions that the Senate had put in around hospitals reporting the number of employees whose duties are primarily administrative as opposed to those providing direct patient care, information about base salaries and total compensation for executive and clinical leadership, and for employees providing direct patient care, and proposals for ways that the hospital can support non-hospital providers, community-based independent and non-hospital providers, and other types of services.
So it seems to be covered in another part of statute. And then if I look at page 13, where we've got number 7, and of course, some of it corresponds with number 9 on page 11. So sorting out what's been taken out overall and what is actually in underlying.
Right. So my
Language.
recollection is the testimony the committee received, at least on numbers 7 and 8, is that the board already receives that information.
Yes,
And then I think,
that is in there.
Yeah.
and then I think 9 was more of a philosophical, let a hospital be a hospital.
Yes, in that it was proposals for ways in which a hospital can support community-based. And I think, again, the philosophical of, is it the hospital's job to come up with ways to support community-based care, or is it the community's job to come up with ways? And again, let a hospital be a hospital. And in particular, and then, then we have other things like choices for care, support for SASH. Should hospitals in their hospital budget requests be notating how they are supporting SASH when SASH is actually only in a couple areas?
Medicare.
And, I think a lot of this is sort of the philosophy around, do we want our hospitals to start
So so
including these
Understood.
things? And Or do we want to encourage the independence and support of those things in the community, which I think we're all aware can be better delivered in the community for higher quality and better value?
So in thinking about this, obviously, we don't want to see is hospitals expanding and buying up all the primary care and all the other substance use disorder, mental health disorder. On the other hand, we also see opportunities where a hospital might have a huge reserve and can provide resources to establish those things in the community. And how do you see that except budget? And we know, for example, the example of the mental health clinic that just got stood up in Burlington. So is it a good thing that it is owned and operated by the hospital? Probably not. That's debatable, obviously. And we do want to reinforce our F2HCs with the work that they're doing with mental health and others. So for me, linking this with going over to the number 7 on page 13, where the budget is excluding money, the intent there was to incentivize hospitals to provide resources for the development of some of the community services. Perhaps it hasn't been expressed adequately, but I think it's independent services outside of the hospital and the hospital can receive some budget benefit by giving some of its either reserves or resources to some of these community-based programs. So that's what the intent was with those two things.
I think I think the intent is good. I just feel as though if we're establishing reference-based pricing, we're allowing hospitals to charge or collect the appropriate amount for the services that they are providing. And we shouldn't be reliant upon hospitals amassing reserves and hoping that they invest it in the community. And, you talked about, say, the mental health crisis that has been stood up. Do we think that was done because they wanted to provide a service in the community?
It was done because the
Or was it
board
done
found
because-
extra money and the money was then dedicated to that purpose. So right now, we know that some hospitals have significant resources and that those resources might best be used somewhere else. So I'm just laying that on the table. It's something for us to think about going forward. Perhaps it's the way it's worded.
Okay,
That's all.
I guess I would just say that, was that stood up for that, or was that stood up because emergency department resources were being
All of the above.
overutilized?
All of the above. So, yes, you're right. Okay.
Both versions do have the requirement that hospitals submit information as directed by the board to maximize standardization and allow for direct comparisons across the system. Section 5 is the Green Mountain Care Board budget review and what that needs to look like. On page 12, the only change is that the House has retitled the plan as the statewide healthcare delivery strategic plan. So you'll see that change throughout. On page 13, the House struck language saying that the budgets established by the board must exclude revenue derived from primary care, mental health care, and substance use disorder treatment services when determining a hospital's net patient revenue and total cost of care targets.
Right. It probably should say independent services, but anyway.
What would, yeah,
No,
I'm not
I'm
sure that's
fine.
independent, okay.
Fine, we will, that was the one I brought up earlier.
Yes.
Yeah. Okay,
Okay, moving on.
yeah, good.
So then everything else gets renumbered, but no changes.
I'm ignoring strategic right now.
Yes.
I tried to change the word to strategery, but nobody would go with that. I would.
City council said no.
Yes, legislative council.
Subsection C is the individual hospital budgets and what those need to do. For the most part, that language is the same. And then we get to on page 16, the global hospital budgets that beginning not later than hospital fiscal year 2028, the board must establish global hospital budgets and have them in place for all by hospital fiscal year 2030. Obviously, as you can see, the House struck this language.
Bad.
Well, I guess, wasn't it? Feels about that.
As I said before, we'll come back to this. This is all about global hospital budgets, and we looked at it in the beginning. And we do understand that ahead may go ahead, so there will be global budgets there, but it would be nice to have a consistent target and have all hospitals engaged in global budgeting.
Yes, and all payers.
Yeah, well, there's only one way to get it, and that's if we start.
Next, we get to what people have been referring to in shorthand as the reverse CON. This is notice of that a hospital proposes to reduce or eliminate service in order to comply with its budget order, and it must provide a notice of intent. And the Senate version had that notice of intent being at least 90 days prior to the proposed reduction or elimination. The House version reduced that to 45 days.
Okay,
That was a request of. That was a consensus.
Yes, or a
number of
compromise.
days, A compromise.
Compromise.
Yes.
Yeah.
with the hospitals.
Yes,
Yeah.
the hospitals were concerned that 90 days was a full calendar quarter.
Yeah.
Right.
It might be difficult for them to provide 90 days.
Okay. Oh, well, and it says not less than, so that adds,
And there was no pushback from.
I'd probably be okay with that one.
Right. It changes in that section. Section 6 is the hospital network's structure and financial operations. And here's where it just struck the definition because it moved up to section 3A, but it's the same definition.
Right.
That's
So
not
that-
really a substantive change.
Mhm.
The substantive change in this section is that the board may recommend any action in the House version, recommend any action it deems necessary to correct an aspect of the structure of the network, but not take action. The Senate version had recommend or take appropriate action.
Is there any?
This is a network, this is a
This
network,
is the
right, so we're
network.
not talking about,
Yeah.
yeah, so I think we're going to probably
Yeah.
agree with this one as well.
Healthcare contracts, section 7, the Senate version had struck this language in subsection, what is now E1 in the House version, saying that the requirements in an existing subdivision do not prohibit a contracting entity from requiring a reasonable confidentiality agreement about the terms of the proposed contract. The House version restores that language and includes the Senate language about providing an unredacted copy of the contract.
Okay.
All right, now we get to the plan and some committees.
Strategic.
Section 8 is the statewide healthcare deliveries, potentially a strategic plan.
I don't know about that.
I think we had robust discussion
I'm sure you did, but
and landed on strategic.
we didn't want a learning plan or, okay. We won't quibble over strategic, right?
All right, so this adds the Comprehensive Primary Healthcare Steering Committee as one of the stakeholders to be collaborated with.
Okay, so the primary healthcare, we need to chat about that.
Yes, we're about to.
We'll get into that. I'm waiting till we get there,
Okay,
just to flag it.
So there are a number of differences in the plan. So the plan shall, and in both versions, align with the Act 48 principles. Those are the principles for healthcare reform expressed in Section 9371 of Title 18. In the Senate version, it said promote access to high quality, cost effective acute care, primary care, chronic care, long-term care, and hospital-based independent and community-based services across Vermont. And then it went on to strive to make these other services available in each region of Vermont. So part of this is just combining what the Senate had as 2 and 3 into one. So you can see those services make their way into number.
Got it. Yeah, I was worried about it at first, and I saw it's actually integrated in, so
Right.
that seems,
There's-
it's not too big a chunk, right? In one,
No, it's a list.
okay, all right. Good.
So that House added identify existing services and added universal access and moved across Vermont from the end to the beginning to all of these different types of care and put primary mental health services in with primary care. So there are no differences there.
No,
Number 3 is new in the House version, define a shared vision and shared goals and objectives for improving access to and quality, efficiency, and affordability of healthcare services in Vermont and reducing disparities in access resulting from demographic factors or health status, including benchmarks for evaluating progress. Identify the resources, infrastructure, and support needed to achieve established targets, which will ensure the feasibility and sustainability of implementation. A number of these were based on some recommendations, I think, from the Vermont Program for Quality in Healthcare. Curious what the lens these are coming in through. Number 5, provide a phased implementation timeline with milestones and regular reporting to ensure adaptability as needs evolve. Number 6 is promote accountability and continuous quality improvement across Vermont's healthcare system through the use of data, scientifically grounded methods, and high quality performance metrics to evaluate effectiveness and inform decision-making.
hold on a second.
Jen, what did you say where these are coming from?
There were some recommendations from VPQHC, the Vermont Program for Quality.
Great, thank you.
And Maria and I wrote some of those.
Nice, thank you.
Number 7 is maintains the Senate language about providing annual total cost of care targets, but taking out including reasonable annual cost growth rates, and taking out excluding revenue derived from hospitals' investments in primary care, mental health care, and substance use disorder treatment services.
So that takes it out, it took it out earlier, now you're taking it out again. It does, you don't have to put cost growth, annual cost growth rates. Tell me why you didn't want to see that.
We have in here somewhere else, don't we, about the growth rate?
I don't recall. Can look when we get
So
there.
you have, then it says using these total cost of care targets. So you have total cost of care and then total cost of care targets.
Right. I'm not sure if there was concern about building in a specific cost growth rate without
Okay.
knowing what that actual rate should be.
I think you're right.
I think the board had suggested removing
I'm
that.
thinking also of independent practitioners.
But the rest remains the same, and then just a little language update
Okay.
here.
All right. Well, we'll just think about that one. We'll sort that one out.
This is the,
Can I?
yeah.
Sorry, I'm just wondering, is that a little bit redundant with what's on top of the page where it says that identify the resources, infrastructure, and support needed to achieve established targets? Isn't that kind of saying the same thing? What, number 7?
I'm trying to remember if we had the
Provide
targets here too.
annual targets for the cost of care.
I mean, those are targets specifically for total cost of care across the system.
Okay.
So yeah, so they may be different targets, or it may be supporting what is necessary to reach those targets.
Okay.
All right, so then we have what the plan builds on data and information from. The House maintained all of the sources cited in the Senate bill, but also added the 2020 report on determining the proportion of healthcare spending allocated to primary care. That was
Yep.
And the 2024 report on blueprint payments to patient-centered medical.
Both good.
Suggestions from the Vermont Medical Society. Then plan shall identify a number of things. So they put in House has put in a new one, opportunities to improve the quality of care across the healthcare delivery system, including exemplars of high quality care to stimulate best practice dissemination. It's again a recommendation based on the VPQHC suggestions. Kept the Senate version about gaps in access to care. And then I tried to get a little more what I think the Senate version was trying to do as well, which is as well as unnecessary duplication of services, including circumstances in which service closures or consolidations may result in improvements.
Yeah.
Has there been a suggestion to add negative effects of closures? And I think you're familiar with negative effects on closure. I think this was looking to identify where there might be some positive effects from closures. Opportunities to reduce administrative burdens. And this is the first of a few instances in which the House was taking out some specific language and leaving these more general. I don't know if the chair wants to speak to that at all.
I may not be the only one to notice, but sometimes when you put in the things such as or may include, what you get back only includes the such as and the may include. It doesn't include the whole. So I think we felt like keeping it as broad as possible means, you know, we have opportunities to reduce administrative burdens. So you come up with ways that you can reduce administrative burdens. We're not going to tell you.
Okay.
And we have some new ones. So this is where the Senate version ended after D, barriers and how they can be removed or mitigated. So the House is adding in priorities and steps for achieving the goals of the plan, barriers to access to appropriate mental health and substance use disorders services that meet standards of quality, access, and affordability equivalent to other components of healthcare, including any disparities in reimbursement rates.
And this was an amendment.
It's a floor amendment.
This was a floor amendment.
Oh,
And the plan strategic plan.
Yep.
Okay.
did your committee take testimony on the floor amendment?
We heard from the amendment sponsor.
Yes, it was part of, there were 4 instances of amendment in here focused on health disparities and parity.
Yeah.
And did your committee vote favorably for the amendment?
On this amendment, we voted 11-0-0.
Okay.
And this gets to the perennial problem of mental health services are paid at much lower reimbursement for commercial insurance than even for Medicare and Medicaid. And we figured, after I just.
Is this the best place for this?
Stripped out the such as. It was in a different section and then we moved it in the floor amendment. Am I correct, Jen?
Yes, there was some, I'm not sure if this one, I don't frankly recall if this one was moved. There was some language about health disparities that the amendment did move.
Yeah.
Okay, so we'll think about placement. But here it's in the plan.
This is
This is part of the strategic.
Yeah, so maybe there's a couple places it could go.
I was just gonna say, for clarity, why not use the word strategic? I'm being nitpicky.
where?
Bottom of page 24, we just, right there, goals of the plan, goals of the strategic plan.
Okay, talk about that.
Well, we call it the plan throughout. Here's
But
plans.
there's so many plans. There's the health resource allocation plan, the state health.
No, this is a whole
plan.
section on the plan. If you would like to refer to it
No,
throughout as the
all right,
strategic plan.
okay. Well,
And type strategic 100 more times.
Whatever you want. Copy and paste. All right, so then we have opportunities, still what the plan is identifying, opportunities to integrate healthcare services for individuals in the custody of the Department of Corrections as part of Vermont's healthcare delivery system.
So I see that one fits in the plan, and some of the others on reimbursement rates. Well, I guess you can identify. How can you identify
barriers.
disparities in reimbursement rates with the group that we have?
I'm sorry.
How can you identify disparities in reimbursement rates from a kind of database place with this kind of work?
We have the Agency of Human Services collaborating with a number of,
You've got a bunch of people coming in and saying, well, I get reimbursed this amount, and I get reimbursed this amount. What, do we have any solid database to look at that? That's why I say, is this the best place for that one in particular? Where does that belong in terms of being able to look at the data exactly? Who's getting paid what independent providers are getting versus what other folks are getting? It's a question. I don't know that any of us know the answer.
Specific to identifying
Identifying.
barriers to access to appropriate mental health and substance use disorder services.
No, that's not the one I'm on.
Well, and.
I am on it.
Reimbursement rate. So that's just a piece of potential barriers.
So the plan is to identify what the barriers are.
Well, we already know reimbursement rates are a barrier. So what we want to know is what are the disparities? So that's why I see this one as you could take a step further with this one. So we'll hold that thought, but just think about it, I guess.
And again, that was the floor amendment.
Right.
Yeah, I get it. No, it's okay.
Okay, still in the identify list, identify enhancements in quality reporting and data collection. Provide a more current and accurate picture of the quality of healthcare delivery across Vermont. And systems to ensure that reported data is shared with and is accessible to the healthcare professionals who are providing care, enabling them to treat performance and inform improvement.
Okay.
The House version strikes out the language specifying who contributes what data and expertise. I think this was more relevant when we had an earlier version in the Senate that had the board and the agency sort of co-leading.
Yep.
And it was important to specify who did what. Now you have the agency leading. And then the House has a different timeline and process. So in that Senate version, Senate had from 2025 through 2027, the Agency of Human Services engaging with stakeholders, collecting and analyzing data, gathering information, and soliciting public input.
Mhm.
In 2028, preparing the plan, and then presenting the plan by January 15th, 2029, with an update every 3 years. The House version would simply have the plan be provided to the General Assembly by January 15th of 2027 and would be updated every 2 years and provided to the General Assembly on or before December 1st every other year, beginning on December 1st, 2029. And the date in there was intentional so that it would fall in the middle of the biennium and have the committees that had already been been learning about healthcare in the first year of the biennium for new members, getting the report before they return for their second.
We'll have to talk about this one, just in terms of the ability of everyone to get together and collate data and then draw some conclusions. So
Is this a good place to?
this is a good place to stop.
We are on the floor. Everybody's on the floor now.
Yes.
Can we meet again? We can't meet at 12. Perhaps we could meet. When do you want to meet? Because you're in charge of this.
I will say, let me ask Kristen, because our floor schedule is a little.
Yeah,
It's dependent upon what the Senate does, I think, today.
we're on the floor. I think we have 3 bills.
Got that
What is
council
the-
bill,
We have a meeting.
the council bill on the floor.
On the floor?
Yeah.
So can we do 1 o'clock?
Vinny and
Let's
I,
try one. Let's try
Let's try
one.
1 o'clock.
What bill is on the floor?
council, being able to prescribe.
Oh,
So
that one.
prescribing by Dr. Level.
Okay.
Is that, is
No,
that on the floor
no,
today?
that's what I'm asking.
Yeah, it'll be fun.
What about 11? Will you guys still be on the floor at 11?
We will be on the floor.
Yes, we'll be on the floor.
Let's say one,
Was this
and I'll
one?
text you if we go, we can text around, if we get off earlier, we can do it earlier. How's that?
Thank you.
Thank you.
Thank you.
Thank